and welcome to this week's Maternity and Midwifery Hour. This is our 13th edition of Series 1, and I'm so pleased. Well, I'm not pleased that it's coming to an end for a little while, but I'm delighted that we're looking at BAME perspectives from the front line, because I think it's very timely. And I'm delighted I have Lola Ornato from Whittington Health NHS Trust and Mala Morjaria. Is that correct, Mala?
It is Morjaria.
Who is a sexual health specialist and midwife. And my name's Sue Macdonald. I am the chair of these hours and the curator. And these were really designed to support midwives, student midwives, people in healthcare and maternity services specifically, while we couldn't have face-to-face conferences and festivals. And we really wanted to make sure we could engage with people and give them interesting things to learn about. And so I have to say a big thank you to Matflix, which does the video streaming from Maternity Expert. They really do have a huge archive of CPD and materials for revalidation. So if you're due your revalidation, midwives, that's the place to get some material up to date and delicious. And also for students doing projects, really useful. Now tonight we're going to be looking at the impact of COVID-19 and taking the BAME perspective from the front line, from the role of setting up services and the kind of day-to-day experiences of midwives and nurses also. And I'm delighted I have Mala and Lola, and I'm going to start them off with a moment of the week, which is how we start. So Mala, do you have a moment of the week that you could share with us?
I've got so many, I didn't know where to start. And
Okay.
I could go all day talking about what wonderful. I think it's just wonderful to be asked to come on the forum. I've always traveled to different sites, visiting maternity and midwifery forum. And this is really a special moment for me because I wasn't expecting to ever be invited to come and speak on the webinar, and I haven't done it before. So I am a little nervous, but thanks to all of you for inspiring me to talk.
Okay, well, thank you for coming, Mala. That's fantastic. Now, how about Lola?
Well, for me, I actually was thinking about what I would choose for my moment of the week, because having watched a number of the midwifery hours and being invited to speak today, my first thought was, what am I going to think of for my moment of the week? But actually one dropped into my lap. So on Monday, I was working a night shift and I looked after a lovely woman and her mother, and she had a beautiful birth in the early hours of Tuesday morning. And just as her mum was about to leave to let her get some rest with the baby, she turned to me and she said, "Can I have your name and the name of your colleague and the maternity support worker who were with us for the birth?" And it turned out that she was a retired nurse, and she said, "I'd like to write a letter and I want you to use it for your revalidation." So I thought, wow, that's such a lovely gesture. So that was my moment of the week.
Oh, that's lovely. That's really good. Thank you so much for sharing both really good moments for us to start the week with. So thank you very much. Now I usually start off this hour just to remind us all about what's happening in the world. It's a weird time. We really want to record our solidarity for all of those who are providing care for people with COVID-19, and also all the people providing care, keeping everything going, and the key workers, and just about everyone. And I think last week I decided everybody practically was a key worker, because everyone has a small contribution or a large contribution to keeping things going, keeping our lives more comfortable than they could be without. But just a few moments to think about some of the people we've lost, and so also some of the people who are unwell at the moment. And COVID seems to be one of the most horrible things, in that some people are ending up not feeling well for a long time, and we just wish them well over this period of time, and hope anyone who's poorly has a speedy and good recovery. Okay, and I have a little highlights from this week's news. And of course, at the weekend, it was the 72nd NHS birthday. Now me, I love a birthday. My birthdays never last one day. So let's make it an NHS birthday like our own birthdays. And this should last not just a day, not just a week, but maybe the whole year. And so I've decided this is at least the birthday week. Now, next week we have our festival online. We were going to be in Leicester, and of course, Leicester's experiencing a lockdown at the moment. So, just to say to Leicester, we're with you. We would be there with you. We're going to be with you in spirit, so that we'll be there next week online. So, and just to remind people, July is Strep B Awareness Month, and just to let you know that the GBS charity have just announced a new Facebook called Due In Group for mums expecting their baby in October and December this year. And these are a really good way for women to talk and share their experiences and find more about Strep B. So there will be information on the Facebook after this, so you can get your information. Now, I had it last week. I started a trend with the best tweet of the week. I'm a bit of an avid tweeter, and it's difficult to choose this week. There were some really good ones, but one I liked was from Cochrane UK, which always have loads of really good, strong evidence-based material. And this was about the diagnosis of COVID-19, very much drawn out from several studies, so really useful. So look out for that. And of course, this morning it's been very much in the news, is the Independent Medicines and Medical Devices Safety Review, which published its report, First Do No Harm, and that was reviewing hormone pregnancy testing, sodium valproate, and pelvic meshes, which have caused a lot of damage to women. Very groundbreaking work, and this was led by Baroness Cumberledge, who's very closely allied with our maternity services. And so, again, there's a link to that report on the resources page for you, so you might want to get that. In fact, there's lots of resources from everything from, now this is new languages, isn't it, over the last few weeks, donning and doffing your PPE equipment, and there's lots of clips of things that will be useful, lots of reading from previous presentations. So that resources sheet will be available to you all. So we're really getting to the meat of the programme tonight. We're going to be looking at COVID-19 and maternity service with a very much a BAME or BAME perspective, whichever you prefer. So we know there are stark inequalities in the maternity health outcomes of Black, Asian and minority ethnic women. One of the stunning things of Black women being 5 times more likely to die as a result of complications in their pregnancy than white women. Astounding, and we need to really address that. Asian women are 2 times more likely to die. And I think over the last few weeks, we've become very aware that also our health workers and midwives, our nurses are also, the BAME midwives and healthcare workers are more at risk also. And we need to think about that when we're working together, quite apart from the other inequalities that exist that I'm sure are going to be emerging from the discussion tonight. So I'm really so pleased that we have our 2 lovely speakers, very glamorous and very knowledgeable about their field. So we're going to start off with Mala. Mala is a nurse practitioner and she's a midwife, and she specialised in sexual health in primary care. She's also edited a text for healthcare professionals on female genital mutilation, and she does have an interest in politics. And there's more about her on the web if you'd like to find out about Mala. But I'm going to not take any time from her presentation. So Mala, the screen is now yours.
Thank you, Sue, and thank you everyone for inspiring me to come on the webinar. I wouldn't really take too much time explaining about what I'm going to say, but what I would say is I'm basically reflecting on my experience of working in COVID-19. This is the hub in Harrow. This actually started on the first day of the lockdown, which really was the 24th of March. So I'm actually going to talk about that. So really, I wanted to say how we started the hub. The hub in my area, I mean, obviously there are hubs, all the hubs were all around UK, but the way we started hub here is we actually had a letter from the CCG commissioning a commissioner who actually asked all the health professionals who were around in Harrow to ask them if they wanted to come and join to start the hub. We obviously didn't know what we were going to be expecting from it, but basically it was about the link between the hospital and the GP practices. So the GPs would actually ring the hub to let them know that they were sending a patient. The patients would actually initially ring the GP, and because they were not doing any face-to-face consultation, they would actually be referred to the hub. The hub doctors would then ring the patient up. So this hub, the model that was actually set up by the Public Health England was there would be 2 doctors, 2 nurses, 2 escorts, and 2 receptionists. And the hub would run from 8 to 8. No one was allowed to do more than three-hour shift to start with. And this was really the link between the GPs and the hub, so that GPs didn't have to send their patients directly to the hospital. The doctors at the hub would assess the patients before they went to the hospital or treat them accordingly. So that the site that we had, the acute hospital we've got, is Northwick Park. So it was just basically making sure that there were not too many people going directly to the hospital. There were times that we would give oxygen therapy to the patients before they actually went to the hospital. A lot of them were given medication which we stocked, like antibiotics, asthma drugs, and we also had direct connection with the pharmacies, so we could write a script and they could use it. So really helping them to not have too many people going to the nearest hospital. We also were referred by 111 services. A lot of hub doctors would actually see the patients in the car park, so they didn't even have to come up. And if there were patients who had come with their relatives, then the escort would only be able to bring the patient to the hub. So when the patients came, they would be wearing a mask, they'd be wearing an apron, and they would be given gloves at the same time. The escorts would be wearing it at the same time. They would be all scrubbed up. When they entered the hub itself, what the doctors would do is they would take the temperature, blood pressure, check their oxygen levels, take a history, and like I said, if needed, before admission to the hospital, they could actually have oxygen therapy, and that's how the hub worked. Now you say, who accessed the hub? So from reflecting at the time, it was a very sad time, because when the patients came, a lot of them would actually talk about other family members who had either died or were or in the hospital or not well. There was a large number of patients from the from BAME. I don't like the word BAME, but I suppose it actually fits in with anyone who is not white. It fits in there. But obviously there is a lot of confusion using that word, which I'll come to you later. We had a lot of over 70s, a lot of men. And I was initially, when I was actually writing down, I was talking to a friend of mine and said, well, there are too many men there. Maybe this coronavirus is a female who's decided to attack all the men here. There were also loads of patients with pre-existing problem, and specifically diabetes, asthma, lung problems. So it was, there were very few patients initially who actually accessed the services without pre-existing problems. We had a lot of patients who actually came because they had other family members within their extended families who were affected, and they really wanted to check it out. At this time, there was no testing at all. It was all symptomatic. And I guess we were all learning. So there were, when someone came and said, oh, I can't smell anything, or I can't taste anything. I think we were learning each day about what the symptoms were of COVID. Now, then we talk about the PPE. Now, I've got my own picture there, only so that it makes life easier. So initially, we started with just the basic mask. This is the testing. This is the car park where the patients would come and park their car so that we would be able to see from the reception who is there, which car is waiting. And only patients who had cars could come here because their cars were the waiting area. So there was no waiting area. They had to sit there. So someone like me, if I was to go and see a patient, I would actually, you had a choice. All these things that I'm gowned up was all available, but it's up to you how much effort you want to make wearing it. I mean, there were loads of people who just wear a white apron and just a mask, and they'd be very happy. But you had the mask, you had the visor here, if you wanted to wear it. You had another plastic gown. You could wear the gown first, then wear your apron. You had your gloves. I'm not wearing a shoe cover, but there was shoe cover, and there's also plastic cap. So you could really gown up and do everything. The people who really bared at dressing up were the doctors. They were completely clueless. And if you look historically, even a week before, they weren't dressing up. Like, somebody came in having a really sore throat. They did wear, no one wore masks because we weren't thinking about it. But now it was kind of becoming very evident, and it's all evidence now that, this is one way of actually getting the infection. So to me, when I reflect on it, it's quite possible that a lot of these health professionals already had the infection and then coming in close contact with COVID again could have just triggered the whole thing off. So when we started testing, this testing was actually in the car parks. So initially, it was all the symptomatic healthcare and key workers. A lot of us were working in the hub, were given the opportunity, but except for myself, initially nobody tested, because testing basically means if you're positive, maybe you need to stay at home for 10 days. And a lot of people, for whatever reasons they had, it was not easy for them to test. I started the process off because it didn't matter if I was working agency and locum for the past 4 months. So it didn't matter if I had to go home for 10 days. And when the results came, the results were texted to the patients. Which made life very easy. And after about 2 or 3 weeks, what did happen was anyone could ring the hub. And as long as they had their NHS number, they could actually come for testing, which was very good. We also had a scheme which was loaning the oximeter, the pulse oximeter, in the area. Now, this was initially started by a community, which was, we have a large Muslim community. So they had started it, which basically, you know, if you had any breathing problems or if you weren't feeling well, if you had this oximeter, you could actually test to see what your oxygen levels were. And we actually had typewritten paper to give it to all the patients who were initially given by our GPs, our doctors from the hub. If they didn't need to go to the hospital, they were given the oximeter, maybe loaned the oximeter for 48 hours. And these doctors would bring them back to say how they were and what their readings were. The GPs also did the same thing, but the oximeter were actually given by the hub. The hub took the opportunity and the distributing from one side. So all the GPs who felt when the patients rang them, and if they felt that these patients would benefit from an oximeter, they were then referred to the hub. So what the hub did was combine the whole system, rather than just it being the Muslim community doing it on their own. It was a great idea to have everyone, the whole area doing it, because then it would benefit everyone. And the CCG commissioner obviously commissioned this service. So we had volunteers who would actually go and deliver the oximeter to patients' home and collect it within 2 days, because we had all the results, and the doctors would actually keep in touch with the patient from the hub, which made a big impact, because then we were not admitting so many patients locally. There was a time when the admission was so much that they didn't have enough places in the local hospital. They had to send them elsewhere. But I think this oximeter scheme was a big success, and it really worked. And along with this community, volunteers from the Muslim community, from the Asian community, meaning, you know, Asian is a big word, but a community that had loads of little pockets of volunteers who would come and deliver food, who would come and, want to help the nurses and doctors to, if they needed traveling, anything they needed, they would actually come and help, which was, it was a great community spirit. Very sad time, especially if you come home and reflect on what went on during the day. I personally, for me, it was very sad time. And at the time, there was no time to reflect on the BAME community at all, because it was saving lives. It was everywhere. No one mattered. It's only when you came home and later on did an audit for yourself to see what you learned, you actually realized that it was very sad that there were at least 60 to 70% of the patients from BAME, which actually does kind of start, you start reflecting on it. So on reflection, you think, okay, so when you look at the professionals, there is the overrepresentation of BAME in the front line. Well, at least it was in the hub where I worked. Majority of the doctors who were there were from Asian community. Half the nurses were also BAME. And, like I said, most of these patients, it's the aging population and the underlying medical factors. So really, it's in this particular hub, I feel that the nursing skills were not used, because the nurses were more like they were told that they were the infection control stars, but basically just cleaning all day. And I did feel that it wasn't, the hubs were great, but it could have been greater, and we could have used the money and we could have used the skills in a much, much better way. So I was actually looking at the future. So there are loads of projects that's online, and one of them that I was looking at was they're actually looking at someone who from the government who is actually going to look at different projects where there is a much more representation from BAME, and make some improvements, because right now, although I worked in a hub which was predominantly accessed by BAME, all the policymakers, all the managers there were no one from BAME, so they were all whites. And although it might sound like, does it really matter? I think it does matter, because when you're telling someone that you got to social distance because you're living in a family with 6 other people, this is very cultural practices among a lot of Asian families, even if they're not all living together and they've got 3 houses next to each other, you might find that they all get together to eat, or they all get together to pray. So I think it's a culture shift that maybe during this time it would have been more effective if there was someone explaining this in a clear form, because they live together doesn't always mean that there is deprivation. At the same time, we got the aging population, especially in Harrow. And we have a lot of nursing homes here too. So a lot of families have kind of really had good faith and put their elderly in the nursing homes, a lot of private homes too. But sadly, we've had loads of deaths where not even family members have been able to go. So this is something where we're actually learning. At one stage, we are actually talking about living together, and you know what, that could have been a very difficult time for social distancing, and sometimes it's a genuine problem where you know you have the grandparents living with you, and it is a smaller house, so you but you're all living together. And I'm sure, you know, with a better understanding of social distancing and how to actually you know, maybe not sit together and eat, have different kind of have different crockery for somebody who is already positive, because you can't suddenly change all these cultural practices or create new housing because they're all living together. They're positive, but obviously at this time of COVID-19, it has proved very negative because we don't know enough about it.
And I think that's a really good place to kind of, it's not finishing the COVID story, but I think you're absolutely right about the degree to which we need to involve BAME communities much more, not just at the front line, but make the front line the much more about the strategic direction, because we as a whole society need to know much more about how different people function and different people work, because that way we can work with them to help them and educate them in how to reduce their own risk.
Yes.
So that was, I mean, that was really helpful, Mala. Thank you so much. That was a really good place. And I must say, having seen the hubs being described on the TV and seen little pictures and, you know, windy car parks, it always seemed to be a windy car park. You made it very much come alive to what actually went on. So thank you very much. I know there's going to be some questions for you shortly after Lola, but we'll move on to Lola now. So I'm really pleased that Lola Ornato is with us. She's been a midwife for nearly 20 years. I don't think she can have been, she's far too young. A keen interest in promoting normality in childbirth led her to accept a job at the Whittington Birth Centre in London, where she's worked for 10 years. She's also passionate about educating women, and that's illustrated by a commitment to active birth classes and educating women and families towards ensuring promoting true informed choice, which we have had a discussion in the preceding weeks about COVID having impacted on the choice. So this is fantastic. Lola, please, the screen is now yours.
Thank you. And could I just say thank you for giving me the opportunity to speak tonight. So I'm going to talk about perspectives from, and this is very much a personal reflection for me, but I've sort of entitled the presentation Perspectives of a BAME Midwife, namely myself. So before we start, I'll just introduce myself and tell you a little bit about what I do. So like Sue said, I've been a midwife almost 20 years now, and I am Nigerian. I was born in this country, moved back to Nigeria when I was 6, and came back to the UK when I was 20. And sort of in the middle of trying to figure out what I wanted to do, I knew that I wanted to do something that involved looking after women in pregnancy. And one day, while I was trying to figure out what to do, and in the middle of an A-level class, a friend of mine, as we were watching a video on midwives, said to me, "I think you'd be really good at that." So I thought, okay, let me look into this midwifery thing. And I fell in love with it. And I trained at the University of Hertfordshire. I spent many years working at Watford, which was my practice site, and eventually moved back to London. And I've sort of worked over a few hospitals in London. And as Sue said, because I am really passionate about midwifery, I took a job at the Whittington Birth Centre, and I've sort of been there for the past 10 years. And now I actually work across 2 birth centres. So I work at a birth centre in South London as well as Whittington. So I absolutely love the job that I do, and I would really, really love to continue to love this job. And just to round off my little introduction, this is a picture of my great-grandmother. So this is Mama Fakeye Faluyi. And she does have an English name, which is Elizabeth, because I think at some point she was baptized in a Christian church. So this is my dad's grandmother, and we've always had this picture in our house hanging up somewhere. But I never really knew what she did for a living. And when I was halfway through my first year of training as a midwife, my dad sent me a copy of this picture, along with a little write-up about my great-grandmother. And it turns out that she was a TBA. So for those of you who are not familiar with that term, a TBA is a traditional birth attendant, which means that actually she was a midwife too. And it was a really beautiful letter about what she did for women and how she would get paid with like a goat or a few shillings here and there, and how she really looked after the community. So I do believe, to be honest, that midwifery actually flows through my very veins. And so on to COVID-19 and how it's affected midwifery services. So I would say that at the moment, we are still experiencing this. The way in which it has affected us is we've had to suspend some of the services. So that's not to say that women cannot be seen, because I think that's the general panic, is that, can I go into the hospital? Is it safe? What's going to happen if I go into the hospital? But because of that, we have had to reassess some of the things that we're doing. And so, for example, things like antenatal classes, a lot of hospitals have had to sort of stop that altogether. And the other way in which we have restricted our services is restricted visiting. So for example, when women come in labor, they are usually allowed to have a couple of people with them. Working on a birth center, we're a little bit more relaxed about things like that. So we are not really into numbers. It's really down to who the woman would like to be with her on the day. But we've also had to restrict visiting just to minimize the risk of infection and the footfall coming through the hospital. So to that extent, the women that we look after are only allowed to have one person with them in labor. So some people will have their partners, and some people will have somebody who isn't a partner, but they feel might support them better. Okay. And I would say from that point of view, just watching relationships, it's quite interesting to see when it's just the couple in labor. Sometimes it works really well, and sometimes you can see, especially from the partner's point of view, that it actually works a lot better when there is that second person there that can also support the partners. So it's made me sort of think about, you know, whether or not that is a good thing from the point of view of the couple's mental health. So I would say with COVID-19 and midwifery, there's been sort of an overall, what I would say an overall sense of heightened anxiety. So wanting to know whether this is going to end, and coming out of this from the other side, what is going to happen? Are some of these restrictions that we've put in place, are we going to have to continue with them for the foreseeable future? But I would say, apart from the women and their families, the staff are also a little bit anxious about, you know, are they going to catch this infection? I've certainly had some colleagues who have had COVID-19. So I would say there's an overall sense of anxiety. So COVID-19 and how it's affected me. So I think the first thing is I have a sense of gratitude. And when I say a sense of gratitude, I mean that I feel grateful that I do have a job, because obviously for a lot of people, this virus has really affected their livelihood. For people who've had businesses, they've had to close down their businesses. So I do feel grateful that I have a job that ensures that I'm always employed. And the other thing that it's made me do is it's made me quite reflective. So I've thought about my job. I do love midwifery. I have started to think about other things that I want to do within midwifery. And I've been quite surprised that I've been able to be reflective, because I think I have 3 small children and my husband is working from home. And after sort of looking after the children, you know, I often go in and do a night shift on top of that. So I was quite surprised that I actually had time to reflect, because there doesn't seem to be enough hours in the day. And I'm sure a lot of people would agree with me that that is the case, that there doesn't seem to be enough hours in the day. But it's really made me think about, am I still happy in this job? Yes, I am for the most part. What else would I like to do? And then while I was reflecting, this happened. So I'm sure everybody is familiar with this phrase. And unfortunately, in the middle of COVID-19, there was a really tragic incident that happened in the States with a man called George Floyd, who was arrested by the police and subsequently died during that arrest. And one of the things that he said was he couldn't breathe. So when I think about George Floyd, my first initial feelings were of anger. And it was very much a sort of a silent anger, if I could explain it as such. Because for me, I was very much, it was a case of, here we go again. And it was also a case of the fact that, of course, it was a horrific way to die, and it was broadcast all over the world. But actually, these things have been happening for a long time, and they've been happening in this country as well as the States. And it was just really tragic. But I think the first thing that I got really angry about was I felt there was a lot of hypocrisy from the press. So, for example, just a few weeks before this, or maybe it was a couple of months, I'm not sure, there was a conversation on a very popular morning show with a woman called Shola Shogbamiminu. And she is a lawyer, and she talks a lot about race relations. And they were discussing the treatment of Meghan and Harry in the press. And of course, a lot of people have said that this is sort of racially motivated, that perhaps she wouldn't have been attacked as much if she was white. And there's been a lot of comparisons to the way Kate was treated to Meghan, and like identical stories where Kate was made to look very positive and Meghan was made to look very negative. And I remember she was being grilled by the presenter, and she was being asked to explain and justify why she thought that Meghan's treatment was racially motivated. And she very calmly answered that actually it's not for her to explain. It just should be accepted that this is what it is. So fast forward a couple of months when the George Floyd thing happened, she was back on the same couch with the same presenters. And of course, there was nothing to debate. But it made me think that, is this what it takes for people to accept that there are these tensions? It actually takes for somebody to be on the floor for 8 minutes and 46 seconds with somebody's knee on their neck and to die, and for that to be broadcast around the world before we can accept that this is an actual problem. So I was quite angry about the hypocrisy in the press. So going on to that, I started to look at how people were reacting, and a lot of the stuff that was coming out was the shock. And again, I was thinking, okay, there is the shock, but we know that there are these tensions. So I found it really, I'm not sure what the emotion is I'm looking for, but I found it really, in a way, unacceptable that this is what shocked everybody. And it was almost as if everything up until then wasn't shocking. It was just something that we had to live with. So I had a lot of mixed emotions to do with that. And I just want to read out a few names before I go on to the next slide. So there's a man called Andrew Okorodu, who was also somebody who was sort of arrested by the police. And it turned out that he wasn't the man that they were looking for. And in fact, they were looking for somebody who was white, who had a completely different description and was wearing completely different clothes, and actually was standing there while they arrested him. And he actually went off with the bicycle that was stolen that they were searching for. And this happened in the UK. And I will get back to that in a minute because of something that will become clear to you in a minute. So what does this mean for midwifery, all of this stuff with race relations? So I think the first thing that we could think about is the Embrace report. And as Sue was saying at the beginning, that the Embrace report is a report that looks into maternal deaths and why women die in pregnancy and childbirth. And one of the things that came out that I think is, really tragic news is that if you are a Black woman, you are 5 times more likely to die than a white woman. So the figures really are, for every 100,000 women, 38 Black women will die. If you have got mixed ethnicity, you are 3 times more likely to die. So the number goes down to 23. And if you are from an Asian background, the number goes down to 13. So Asian women are twice more likely to die. If you're of mixed ethnicity, it's 3 times more likely. And if you're a Black woman, it's 5 times more likely. So when I think about these figures, I think about how people have reacted to what's happened. And social media was a real eye-opener for me, because actually on social media, people sort of sit at their keyboard and they type their thoughts. And I think that what people type are what is in their minds. And for me, it was really depressing to see the responses to some of the things that were happening. So I've had people say things like when the Black Lives Matter movement were doing their protests, people were saying, you know, why are these people out? You know, don't they know that the COVID-19 is going to spike? I had people that were sort of saying on social media, well, I'm done with this Black Lives Matter, all lives matter. And there were also people who were sort of really, to me, were just deliberately choosing not to see what was in front of them. And I think when I look at it, I think it's not just it was people. Some of these people were midwives, healthcare professionals. So when I relate it to the Embrace report, I think if those are your views, and if we as the BAME community have to sit down and try and argue our way through having equal care and argue our way through why the Black Lives Matter is so important, then when you look at women coming through our doors and you potentially have staff who have these views, then how can those staff really genuinely treat people with equality? And it's a really harsh truth. And it's not about, I'm not targeting certain people. I'm just trying to get everybody to see what I'm trying to say here, that there are people who have those views, and it could just be that's the way they've been brought up. They generally don't see a problem. But we have to be honest about this. And we have to say that if we have people who have these views within the healthcare profession, then there is no way in which they can treat everybody with equality. And I think that's a very harsh truth, but I think that one of the ways of moving forward is that we need to confront this, and we need to acknowledge that this is a real problem. So I just wanted to very quickly give you a personal experience about something that happened when I was a midwife a while ago. And it's just really because I've been reflecting about things a lot. I'm hoping that by telling this story, it might make people reflect about maybe things that they might say, or maybe things that they've heard in the past as well. So I was doing a night shift on the postnatal ward, and I was working with 3 other midwives. They were all Black midwives, and there were 2 maternity support workers on the ward that night. The maternity support workers were white, and at some point during the night, a woman came up to the nursery where the maternity support workers were checking the equipment, and she asked for some breastfeeding support. So one of the staff, one of the MSWs had said, we will come and help you, go back to your bed and we'll come and help you. Now, as the woman walked off, I'm not sure if they said anything about the woman, but they certainly said something and they laughed. So the woman was quite upset about this. She complained to her husband, and in the morning, the husband made a complaint. So because the woman was quite sure where she had gone to get the help, when one of the MSWs was questioned, she denied that it was her who had laughed. But what she then said was it was the African midwives who were in the office who were chatting in their language that had laughed. So when I heard this story, it made me laugh a little bit, because I thought, well, I'm Nigerian. So in Nigeria, we have 250 odd languages. I speak one of 3 major languages in Nigeria, and I speak English. My aunt speaks a dialect of Yoruba. So when she speaks to me, I understand her 60% of the time. 40% is just nodding, really, and like agreeing with what she says. So for me, I thought it was quite an ignorant statement to say the African midwives in the office were making these comments, because I remember this, and this was quite a few years ago, but these things stick with us, as they do with the women that we treat. And that's why I always think it's really important that we have to be very careful about the way we talk to each other and the way we talk to the women that are in our care. And I remember when I was a student, somebody saying to me, women will always remember what you say to them when you're looking after them. So you need to treat them with respect and dignity. And when I look back on the midwives, I remember the midwives I was working with at the time. And I remember one of them was from Zambia, one of them was from Kenya, and one of them was from Zimbabwe, and I was Nigerian. So it made me laugh, because I thought, what language did this maternity support worker think we were talking together? But it was also sad, because I felt that there was a definite lack of understanding and a lack of wanting to understand and wanting to treat everybody with dignity and respect. So on to the next slide. Okay. So when I think about how this will affect my future practice, I think I will definitely be more outspoken. So one of the ways in which I'm being more outspoken is actually doing this. I feel that I want to do something to change things. the cynic in me thinks I have lived with this. I remember in 91 when I was 15, and we had the Rodney King incident, which was also an American man who was beaten by the police, and it was filmed, and he was a black man, and he was beaten by these police, and it was blasted all over, the TVs and everywhere that we were. But I feel that even though I think that maybe things will not change or will take ages to change, I cannot sit down and do nothing about it. So I'll be more outspoken about things. And by being more outspoken, I just mean that hopefully by doing this talk, if I've reached one person today who might think a little bit more about these figures, that will be good. And the reason I say this is that I actually remember somebody saying to me on social media that they were really upset about the figures from the Embrace report. And when they tried to talk to a midwife about it, this midwife actually said, this is just not even true. So I think I will continue to speak. I will continue to have dialogues. I absolutely, like I said, I'm very passionate about education. I know a few students who have reached out to me on social media, and I will be, hopefully, fingers crossed, on the 15th of December, I will be doing a talk with some students at Staffordshire University based on, how we treat BAME women and based on experiences that I've had, just so that they can understand a little bit more, and perhaps it will affect their future practice. So that's what I'm going to do. What will you do? So when we think about when I say what will you do, I mean, they are all very small, simple steps that everybody can take. The first one is do not stay silent. I know that it's a very difficult and uncomfortable conversation to have, but I'm sure that we've all been in situations where somebody has been treated unjustly, and maybe they've been treated unjustly or not treated well because of the color of their skin. So have those conversations, and it's not about having a shouting match in the middle of the ward, but you can take whoever is doing this aside and say, look, I don't think that was right. I think also when we look at our senior staff as well, and I think Mala also brought that up in her discussion, look at your representation in senior posts. It's not enough to just say, oh, they don't come forward for the interviews. We need to dig deeper. Why are the BAME community not coming forward for these interviews or for these posts? Why are they not applying in the first place? It's not enough to say, well, we invited them, but they didn't come. I've been involved in quite a few community projects, and this is nothing to do with midwifery. It's just things like the school and church and other things where I live. And whenever I bring it up that we are not reaching the full community, sometimes the attitude I get is, well, we've put it out on Facebook or we've emailed everybody and they haven't turned up. And I try to say to them, some cultures are really different. You actually have to go right up to them and say, we would like you to be involved in this project. So I personally feel it's not enough to say, well, nobody came forward. We need to be actually looking into why people are not coming forward. But also, if we think that we are representing the BAME community in midwifery, we need to have BAME midwives also who are going to be there, maybe to advise and to help and to give suggestions as how we can make this care better. And involve BAME staff in decision making. So again, I think it's really lovely sometimes that we want to do things for the BAME women in our community, in our care. But I think it would be really good to involve staff and say, do you think this is a good idea? Because somebody actually said to me that it's a good thing that we have recognized that BAME women are more likely to die. But also when we think about it, if we then put BAME women in one box and say, you get all this care, we need to also ask those women, because they might start to feel a little bit marginalized and, are they a problem? So we absolutely need to be including our BAME staff and our BAME women in their care rather than making the decisions ourselves. And the last thing I would like to say is also to educate yourself. And when I say educate yourself, I mean very, very politely. I love to talk. That is my passion. That is what I'm putting into what I'm doing right now, talking. And I don't mind having these conversations, but I think what's really important to know is that we are not the spokespeople for the BAME community. So we are not here to answer your questions 24 hours a day, 7 days a week. So if there's something that we want to talk to you about, don't get offended if we don't want to talk about it, because it could be that that's the 7th time that day that we've been asked that question. So for example, when the George Floyd incident happened, a friend of mine she rang and asked me how I was feeling, and I had done nothing but speak about this. And I know that for her, it came from a place of wanting to care for me, but I very politely said to her, I just really don't want to talk about that. And then I proceeded to talk about it for 20 minutes. But that's what I mean, is that there are resources that you can access to find out a little bit more. And I just want to end with an example of how sometimes you can target one person and say, I want to talk to you about this and I want you to give me all the information. So again, another sort of fairly popular TV presenter who had been very sort of disparaging about Meghan and Harry, but was all over the George Floyd incident, was interviewing a musician called Dizzy Rascal. And he was interviewing Dizzy Rascal about something completely different, but then decided to ask him about the Black Lives Matter movement. And Dizzy very politely said he didn't really want to talk about that. And the presenter then tried to make it about him being aggressive. And suffice to say, Dizzy Rascal put him in his place, which I'm very happy to say that happened. But again, I think it's about understanding our feelings. So including us, understanding our feelings, educating yourselves, do not be silent, and involve us in the decision making. And just very finally as well, I would just like to say again, thank you very much for the opportunity to talk, and I welcome any questions.
Thank you very much, Lola. Thank you, both of you. I think you've given everybody a lot of things to think about, actually, because there's an awful lot around what we take for granted, and also about working together and being critical of the assumptions that we all make, and kind of trying to understand how each other's work, and sort of cultural competence, knowing, one, not making an assumption that one culture or one group of people function in one way. This is about getting to know each other anyway, and people, especially if you're working together, this is what you should be doing all the time. Anyway, we do have a few questions, and we're allowed a little more time tonight to answer some of them, hopefully, all being well. So I've got a first question from Susan Vining, who says, wow, I'm really surprised to hear Mala say that health professionals could choose how much PPE they chose to wear at work at the hub. Even at the beginning, shouldn't they have all worn the same to provide the same level of care? What do you think, Mala?
Yes, I agree with you. But at this stage, we were all agency workers, ad hoc workers, and all the PPEs were sitting there. And although it was, look, wear the apron, wear the gown, wear the apron, wear the mask, and wear your gloves, that was it. The rest was sitting there, and it was up to you if you wanted to use it.
Okay. I seem to recall saying, this has been shown a lot on TV, and the same sort of thing seems to be recaptured, because it seemed that some people wore everything and some people wore a little bit.
Yeah.
So that probably was because if you're out in the fresh air, your risks are slightly less than if you're in, for example, an intensive care unit, where you have to be completely donned and then doffed. Thank you, Mala, for that. Now, I'm racing on because I want to get lots of questions in. Sharon Tunnicliffe says, definitely involving BAME staff and women in making positive changes is really evident throughout the pandemic. So that's really a comment than a question. Jane Marshall, hello Jane, says, I totally agree. From the media coverage of Leicester at the moment, the BAME community is feeling very vulnerable, as living in large communities is their way of life, which I think, Mala, you kind of expressed very well. So I think these are comments. Sharon also thought the using pulse oximetry was a good thing. And then Gillian Ireland says, it's our responsibility to be with women, all women, end of story. Okay. Now I'm looking for a question now. I know there are a few coming through. Jenny Hall says, thank you, Lola. Question for you. We know there's been a bullying culture across midwifery for many years, and there is also racism. Have you any suggestions about what we can do to change this culture, as it's so difficult to change people's attitudes? Forgive me for looking over here. This is where the questions are coming in.
I would say that really, for me, I am looking at what I can do differently. And I think if everybody looked at what they could do differently, we would come up with solutions. And no, we are not going to change people's attitudes. We might change a few, but we're not going to change everybody's attitudes. But I think also at the same time, that's not an excuse not to do anything. I definitely think that there needs to be more, we have our sort of mandatory study days. There needs to be more about understanding the BAME community. And I just wanted to very quickly say something about what Mala said, and was actually in my presentation, I forgot to say it, was even just the language. When I started midwifery, I used to say deliveries a lot. And then when I got into it a lot more, I thought, actually, that sticks in my throat. I can't say delivery, I say birth. And I think even just the basic language. So BAME, if you think about the word BAME, it stands for Black, Asian and minority ethnic groups. And today I was going over that and I was thinking, for me as a Black person, the one thing that stands out in that is minority. And it already makes me feel I am less of a person than a white person from that. So I think it's just even the little things. And I know, I've heard people say, oh gosh, the world's gone politically correct mad, but I looked at minority on something today, and I was looking at the definition of minority. And when it was looking at minority groups, the definition of the minority was not necessarily the fact that they are a smaller population, but it was saying that it was a population that is not indigenous of a country and that are considered inferior. So that very word, so I think it's all about education. There definitely needs to be more. The students that I have spoken to, I spoke to 2 students and they said the same thing. They're both at different universities. They said when they had their lectures, it was very much a case of, we're ticking that box and it's done. And they were both Black midwives. They felt that it was not treated very well and they were upset about it. And one of them actually said, based on the lecturer who was handling the lecture on that day, who was actually a white woman, she felt that she was not going to attend the lecture and she didn't. And it's just those little things, like if you are going to talk about the BAME community, there's nothing wrong with with somebody who is not from that community running it, but you have to have people involved. So for me, it's always education, education, education.
I'm not going to disagree with you at all on that one. I think, and there is a link to a woman who teaches. She's in her 80s now, but she teaches in America, and she's an anti-racism activist. And she is the woman that did the brown and blue eyes experiment. And I would recommend anyone who's watching this to access that YouTube video, because she's developed the blue and brown eyes experiment in a much harder edged way in a high school with a group of kids who were Black, and the kids who were, and then other groups like Native Indian and white, and swapped. It was absolutely gripping and very thought provoking. I think that would have changed attitudes, and that sort of learning might do to be a bit scary to do, but might be worth taking. But do have a look at that. Okay, I've got another question from Olabisi Mariam Shitu Bapatundi. Goodness.
Olabisi.
And she says, is there any exception to the rule for those women known to secondary mental health with chronic anxiety and fear of childbirth as to having their partner as support? And that, I guess, is going back to this issue of only having one person or not even having that person there at birth.
So I would say sadly not. I can completely understand why that would be an issue, to have, more support around you. But I would say from a midwifery point of view, and just where I work personally, that the women are really well supported, and that the actual labor and birth is a very small part of becoming a mother and looking after the baby afterwards. So I would say that really it would be the support once you get home with the baby that I would be really concerned about, and be hoping that you still had those links, which I think that would be, that would be a given. But unfortunately, there are no exceptions.
Okay, that's fabulous. And I've got someone saying, Rosamond McFadden says, Lola, I could listen to you for hours. As a white British student midwife, I chose for my dissertation the subject of inequalities of BME women in the maternity services. I agree, but our colleagues need to understand their bias and choose to reflect and educate themselves, as all we do. And should add this was in 2009 and it hasn't changed. That's a bit sad. I think we need to do a lot of work. And this is a changing time. So maybe at the end of the COVID, we will have a different look at this, a different attitude, different feel for all of our communities. It would be nice to think so. Now I've got a question from Sarah Ezegbona. Do you think we need more emphasis on cultural competence, unconscious bias, or cultural intelligence training? I'll start with Mala and then move on to Lola.
Okay, that's really great. So I've actually got something that the government recognizes that we must shine a light on burning ethnic disparities, which is great. However, I've actually done loads of projects where you have policymakers, program providers, communicators who use words that people don't understand. So if you were to ask people what BAME stands for, and whether they fit into any of it, or what BME stands for and where they fit in, you would actually be very disappointed. So if we have the first layers who are not making any impact on anyone, can you just imagine how we can have this gap that we can actually solve the problem? The gaps are going to be there because the policymakers are just not making much sense. And you need a foot soldier who is actually doing the work. It's no point giving the money and giving the project to someone sitting in the parliament who happens to be from a BMA community to say, look, you know what, we have decided that there's been too many deaths. We've got evidence that this community is not doing well. So you, as someone from BAME, we would leave you to do it. That person is sitting at the parliament. I mean, she could have a Nigerian background. She might know everything about them, but she's not actually coming down to do anything. It's just money. And we're just doing exactly the same thing, where everybody looking at the CCG, who is actually commissioning the services, are all known. They're not from the BAME. And people providing the services are also not from the BAME being represented. You could have someone like me with so much experience and so much that I could do, but that is not the thing. That what I can do is it's what we've already got. We're not prepared to change. So everyone who is there is already there and is always going to be there. So unless we have a foot soldier doing all the work and getting the audit, it's no point giving someone in the CCG all the money, and they're the ones who are doing the audit too. So what difference would it make? You need someone to do the audit from outside and come and work.
I can foresee a good political career for Marla. She's, I mean, this is going
Absolutely.
back to what you both said. You've both said about real, proper involvement, not just tokenism, and real involvement across the way, and not just thinking, oh, we've sorted out BAME. Yes. We've just got that person, they'll sort it out. So thank you for that. How about Lola? Would you want to say anything?
So Sue, just ask the question again, because I missed a little bit about the there was something about culture that she asked.
Yeah, do you think we need more emphasis on cultural competence, unconscious bias, or cultural intelligence training?
It is a difficult one. I mean, I think the one that jumps out most at me is the unconscious bias, because people don't know that they're doing it. I mean, to be honest, I'm not sure whether they don't know that they're doing it or they've just never been in a position where they've had to think about it. And I think a really good program to watch at the moment is The School That Tried to End Racism, which is about, because, you talk to these children and, some of them have never had to think about it. And some of them, that's all they think about. So I definitely think just even having a study day on that alone for people to be put in groups like those children just to get to the very basics of unconscious. People don't understand it. I still have people saying all lives matter, and they don't understand that the whole thing about Black Lives Matter is the fact that we are not being treated equally. We never said all lives don't matter. What we're saying is we'd like our lives to matter too. And I spoke about it to my 11-year-old and my 9-year-old, and they understood it very well. So it does leave me with the notion that people kind of know, but they don't want to, some people don't want to confront that. It's a lot easier for them to be defensive about things than it is to confront the truth and say, actually, if I walked with you into a shop, perhaps I would be followed around and not my white friend. And that is the bottom line. So I think definitely starting, for me, I would say just workshops on unconscious bias first, because I think culture, I mean, there's so many different cultures. I mean, like I was saying with the languages in Nigeria, like 250 languages, I speak one. I don't understand my aunt that speaks a dialect of that language. It's very difficult for me to say I'm the spokesperson for Nigeria, you know, I'm not. So I think we definitely need to just be working on, there's so many things that we can do that might seem like a little thing, but we're not doing them at all at the moment, and we need to start there. So I think for me it would be the unconscious bias, just for people to know just that little thing exists. That is actually, it's not little, it's a big thing. It affects a lot of people's lives. And then we could go on to the cultural competency and all the other bigger things. But I think predominantly it's about the fact that, unfortunately, if your skin is not white, especially in midwifery, you are more likely to die than a woman whose skin is white. And that's the bottom line. And we need to do better and look into these figures a lot more. And we just need to do better, basically.
We do. We need to address it, and I think the issue about the bias and that particular program has been very interesting, because it's very disturbing for all of the kids, but especially for the white kids, because they're having to think about something they haven't had to.
Yeah.
Because they just take it for granted. All the privilege, this is the white privilege that we just take for granted because we've got it. We didn't even know we had it in a way, but it's there, and we have to deal with it and make things more equal.
Yeah,
and
absolutely. Absolutely.
Yeah, I think we do. Do you know, I could talk to both of you and listen to both of you, because you've got such a richness. We've had all this thing about the hub and all the underpinning political stuff that Mala's been sharing, and the projects. I'm going to have to invite both of these people back next term, next series, because you've been absolutely fabulous, and thank you so much for your participation. And I hope that we have got one or two questions, but we've got a lot of very positive comments. So I'm hoping that Lola and Mala can actually spend a bit of time just sending some comments back to people who've joined us online. That'd be fantastic. So thank you so much to our speakers. Resources will be available on the website after this, probably by later on Friday afternoon. Remember, there's no maternity or midwifery hour next week. Oh, but we're taking a little break. But there is next week. There is an all-day Midlands Festival online on the 14th of July, which is Tuesday. Which do register if you haven't registered. You can watch the whole day. I have to say they're fairly addictive, so if you start, make sure you're equipped with water and food and things, because you might not want to leave, or if you just want to pop in and out, you're quite welcome to do that. And in the meantime, this has been such an honour and privilege. The whole tonight, especially, but his series has been lovely. And I'd just like to say to people who've joined us, thank you so much for coming to join us. Stay well, stay safe, and give your loved ones an extra hug.
Thank you, Sue.
Thank you.
Thank you.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.